Thank you, Mr. Chairman. I just got to piggyback on and remind my friends across the aisle. The ACA is broken. 24 million people, their average deductibility is $5,000. That's not in access to health care. If you're a family making $80,000 a year, a $5,000 deductible is not access to health care. And regardless of what we do in the next month or three, your premiums are going to go up at least 18% for the ACA plans. I'm just so waiting for you all to say, we need to fix the fraud, we need to fix the cost, we need to fix the deductibles as well. Simply throwing money at a problem, it doesn't solve the problem. We need to actually go after the true issues, fraud, the premium increases, and the deductibility. But first, we need to get the government open. All right, let's turn to 340B, something I'm pretty familiar with. You know, the 340B started off as a wonderful program. And my rural hospitals, my community health centers are so dependent upon them. But it's interesting to me, like many things in healthcare, my rural hospitals only get less than 2% of all the dollars spent on 340B go to rural hospitals. Only 2%. Our community health centers, I mean, one of the greatest things that we've done and that we need to continue to fund more are these community health centers. You know, one of my MAHA pillars is meaningful, affordable access to primary care, integrating mental health, integrating nutrition. But the 340B program, vitally important to that population. But what we've seen, of course, are big monopolistic hospital systems abuse the system. And, you know, frankly, they're taking 95% of the dollar, 94% of the dollars go into those. So it's not being spent where it should be, and we're here today to fix it. I'm frustrated that I know we formed committees, we prayed about it. Before we leave for Christmas, I hope that we have a legislation passed through committee, marked up, and I think we're real close on what that looks like. I think it's time to quit thinking about it and wondering. We know what to do. We absolutely know what we need to do here. One simple thing is defining a patient. There are big hospital clinics that saw a patient 5 years ago. The patient has moved out of state, and they're still using 340B for a profit center to sell to those patients. So I think I'm going to start with Ms. Rosenberg. Any thoughts about how you would define what a patient is in these 340B programs?
We have not specified a specific definition of a patient, but we do have an open recommendation to HRSA to clarify its guidance.
So what is it? What does the definition look like?
I think that is up to members of Congress. What I can say, things to consider may be the frequency or the recency with which an individual had been served by the facility. One thing to consider is whether or not it should be a per prescription basis or not, and whether or not the drug that they're provided is at a result of a visit at that facility or from a referral from that facility, or is it unrelated? But those are things you could consider.
Dr. Sid, would you add anything to defining a patient?
No, CEO would not make the kind of recommendations about how to define
Is it
patients.
important? Would it make an impact if we did?
We would certainly analyze that based on the specifics of how the patient definition was set. And I think, I expect that any sort of narrowing of patient definition would, of course, have implications for spending in the program.
Okay, let's talk about PBMs for a second. I think Senator Cassidy, Chairman Cassidy, he cited a GA report, the concerns with the PBMs, and I appreciate the continued investigation into this. Let's go back to Ms. Rosenberg. Since the fee structures are generally the same for grantees like community hospitals, community health centers, and hospitals, would you say this places a disproportionate burden on grantees who typically operate on much tighter margins? And what transparency requirements could help us implement and prevent the divergence of resources?
So certainly the compliance requirements are the same regardless of whether you're a grantee or a hospital. And so if you're a smaller entity, then that may be more challenging. In terms of transparency, I would note that HRSA does not have insight into contracts that entities may have with third-party administrators or others to help them.
But you would agree that PBMs are taking a chunk of this money?
We haven't looked specifically at PBMs. We have looked at third-party administrators, and they do get paid for their services.
Is it a significant amount of money or not?
We don't know. That's not something that there's.
That's the problem. If you don't know, then I don't know as well. Mr. Chairman, I went over my time. Again, I just beg this committee to mark up a bill and let's get this done. Thank you.